Everyone.
Good morning.
So for those of you in the room, I'm J.M. Padini. I'm the Development Director for the National Organization for the Reform of Marijuana Laws. I also serve as the Executive Director of the state chapter of Virginia NORML. And this morning, we're going to do a quick review of patient access to medical cannabis in Virginia and highlight what are the overarching patient issues. So a little bit of background. Virginia NORML provides a comprehensive website with information regarding cannabis, including medical cannabis in Virginia. This is where most patients in Virginia are getting their information about the program from. We have for 5 years now provided a hotline that my colleagues staff and answer these patient questions day in and day out. The phone still rings every day, weekends and holidays, with questions about medical cannabis. And then we do some live content every week and answer questions live. We get emails and we get questions on our social media. So we really are blessed with the opportunity to see where patients are in this program and what their attitudes and opinions are, as well as their concerns. So I've broken this out into what the three major buckets are of concerns, and the first one we're going to address is limited points of access.
With questions about medical cannabis, and then we do some live content every week and answer questions live.
That's fun.
We get questions on social media, so we really are blessed with the opportunity.
Excuse me. Thank you. So the limited points of access in Virginia are rather obvious given the number of sites that we have, which is fairly low for a state of this size. And this just created geographical inequity. And then we also have the HSA 1 license, which is still in lawsuit. So you can review this first slide that has a map of the HSAs. If it were in color, you would see that HSA 1 is that very large green one, which is basically the top half of the state. There are no licenses. There are no dispensaries operational in that portion of the state at all. So in HSA 1, there are 0. In HSA 2, which is the smallest geographically but most dense from a population standpoint, there are 4 dispensaries open. In HSA 3, there are 4 dispensaries open, with a 5th one coming soon, and that will be, certainly an improvement for that area of the state, which is the largest geographical HSA. We've got HSA 4, which is where we are now. There are 3 open, with a 4th slated to open soon, and then HSA 5 is also the same, with 3 open and a 4th opening in January. The next slide will provide you with a mapping of where these operational dispensaries are. I don't know if you can see a difference between the yellow and the green, but the 2 that are slated to open soon would be hopefully a lighter shade. But just observing this, you can see how there are great distances patients have to go in many instances to access medical cannabis products. Now, yes, we do have delivery. It's very fortunate. We didn't have to struggle through that legislatively in Virginia. But still, most patients want to go in person, see what there is, know what they're getting first before they engage in delivery. Virginia, as I said, has 14 open medical dispensaries, 3 slated to open soon. This model that we began work on back in 2017 allows the state for 30 total possible dispensaries at the end of this build out for this model. We have 8.63 million people in Virginia. So let's compare that to another state that also has both medical and adult use, has 7 million people, so, fewer. Is certainly a more mature market, but most medical markets are more mature than Virginia's. This is Massachusetts on the next slide. Massachusetts Cannabis Control Commission has a great website. You can it will generate a map for you based on if you want to see where medical dispensaries are, if you want to see where adult use dispensaries are, if you want to see both. So this map is of their medical dispensaries, which you will see are 88. Again, yes, a more mature market, but I show you this so that you can take a look at, yes, it is a smaller state. It has similar policies to us, but it is, as the market has matured, has reached a number of 88. All right, so next we're going to go into patient issues, consistent product supply. Patients oftentimes are having to wait for products to be replenished or available at the dispensary that they shop at. And oftentimes when products are replenished, they come with a different name. This is very confusing for patients because they know that Unwind 1 was the medicine that helped them go to sleep. And then they go back to find Unwind 1, and it's not there. Unwind 2 is. Is it the same thing? Well, yes, arguably it is the same thing, but we have these regulatory impediments in place that not only make approval of these products slow, makes restocking difficult for the processors because of the slow approval process. Any of these very minor variances in the product formulation require a new name, and that just adds confusion for patients. I want to highlight that this consistent product supply issue is due to regulatory impediments. It isn't that these companies don't know what patients need or want. It's how we have structured it in the Commonwealth that makes it difficult for both patients and the producers to navigate. Now, we passed legislation in 2022, an operational efficiencies bill, to address these exact impediments. But the regulations from that bill have still yet to be implemented. And here we are now preparing for 2023 legislation where, again, we're potentially looking at addressing these same issues that we tried to address a year ago. And then this will be the final bucket. It's very visually heavy, so please enjoy. Patients have extraordinary confusion over what is an actual licensed, authorized dispensary and medical product in Virginia. We do not regulate in Virginia who may use the word dispensary. If you want to open a business today and call it a dispensary, you can. And we leave it up to patients to know the difference. We even have pharmacies in Virginia that are selling unregulated products. They label them pharmacist formulated, whatever. So imagine this, you go in to pick up your asthma medicine. You see, oh, this is formulated cannabis product. Well, this must be the same. Why don't I just get it here at this pharmacy instead of the G-Leaf pharmacy? And the state continues to impose restrictions on how the medical companies may advertise. And I don't mean flashing neon signs, right? I mean communicating the most basic information to consumers that they are open, that they can get certified and come in and buy products that are safe and regulated. To illustrate this for you, yesterday I did a quick search, medical dispensary Richmond. So that's a slide you got there. And take a look at that list. We have 3 medical dispensaries in the Richmond area. You don't see 3 medical dispensaries. You see a list, and you as a patient now should decide which is real and which is not, which is regulated by the state and which is just some store. It's unfair for patients to have this knowledge and to be able to make these choices. And often they'll shop at stores that are not regulated, and then we will get calls about the harm that they've experienced from these unregulated products. It's not uncommon. I don't share that to be hyperbolic, but we get calls every single week how someone ingested a product and they felt terrible, and can we please help them get that to a lab to find out what it was. Next is a picture of G-Leaf. This is what a medical cannabis facility in Virginia looks like. There is a sign with the name on the building. That's it. Yep, that one.
I was going to ask people to hold questions, but I've got to ask, at this point, on G-Leaf, on their facility, it does not say dispensary. Is that, are they prohibited from saying anything beyond the name of their firm?
No, some of our dispensaries do have meaning hours in Virginia, not mine personally. Some of them do say, a medical cannabis dispensary. But it is small, it is understated, and the buildings themselves tend to look unobtrusive, uninteresting, other than the sign that has their name on it, which may include a medical, the language that says a medical cannabis dispensary. You would have to know what it is.
Thank you.
And this is something that we regulate in Virginia, right? We limit what they can put on their exterior. The windows are opaque, the doors are all locked, there's security, there's patient registration verification in order to enter the facility. And you can also see the amount of security on the exterior with the cameras. Now we're going to just hop down the road to Virginia Beach and take a look at a place that refers to itself as a dispensary. This is on Atlantic. This is a heavily trafficked area with lots of visitors, lots of residents. You can see neon signs. You can see the doors are open. There is no security. Apparently, they claim you can purchase legal THC there, as well as dank gummies and stun guns. Very different than what a regulated cannabis facility looks like in the Commonwealth. But again, patients, consumers, why are we expecting them to know the difference? In front of this store, these pictures are all from the same location. In front of this store is a car, which as you can see says, "Ask me about free samples." And presumably the person in the car is giving that person a free sample. We didn't stop to ask, but this is right in front of that store. The next slide, you can go into the store and you can see that there is no security at the door. All of the products are out on shelves, not behind glass, not behind counters. There's signage on the wall making blatant health claims about cannabis compounds. Certainly, we would not permit that in Virginia. It's also prohibited by the FDA. So, wrap up here. There are some potential program improvements we could explore in 2023 session to address some of these issues. I think what is most critical is finalizing the transfer of the medical program to the Cannabis Control Authority, to a regulator that has the bandwidth and the funding to grow and properly administer this program. When we look at expanding retail access points for consumers, a more nimble way, and what many states have moved to, is authorizing the regulator to assess demand and issue either applications or an RFA. We can work to expand access to certifying practitioners. This could include on-site certifications. And we certainly should improve the permissions for disseminating basic information, which we would call advertising, for the medical companies. And before I hear your many questions, I want to highlight that, yes, a number of these issues could could be addressed through a comprehensive legislative effort that simultaneously regulates adult use. But many of these issues are specific to the medical program and will not simply be made whole by rolling out adult use. So yes, we could do a lot, but there are still important issues that are specific to the medical program, and this isn't an either or. This isn't, we don't present this as the opportunity. So you should choose between medical or adult use. These are both valid policy tracks in Virginia and that deserve your time and consideration. And with that, I cannot wait to hear your many questions.
I'm going to start with Delegate Adams, who's been patiently waiting.
Thank you, Mr. Chair. I have a lot of questions, but I'll just try to do a couple and then come back later. Let me just go. I had to do them by page. My first question was, who determines the location of the newer dispensaries? Because I'm just looking at proximity, for example, where it's population dense, obviously that, but in Abingdon and Bristol, which I think is where the next one is, Bristol is going to be. They're pretty close in proximity, given the other parts of the region. So how do they determine what would be a geographically appropriate dispensary placement?
I imagine that would be an excellent question to ask the processors themselves, but I can also add that they are restricted by the localities which will accept them. And we have recently encountered that in this health service area.
You're right.
Where localities, despite medical cannabis being explicitly legal under state law, being protected under federal law, we still have localities that are rejecting the location of medical cannabis dispensaries within their jurisdictions. So it is what you alluded to, where the patient population is, but also will the locality even allow that location there?
And the follow.
I just want to follow up to your question and come back to you. Sure. When you said it's up to the locality, under what authority does the locality have? Is this zoning authority, or is this something that was explicitly granted in the medical cannabis?
Yes, I think that the issues we have run into during location is typically in the zoning process, where they've been unwilling to issue a variance because of claims that their existing ordinances prohibit the location of such a site.
Thank you. Delegate Adams, why don't you continue?
Yeah, and follow up, Mr. Chair, I was just curious if I guess what you're saying by regulation, there is no regulation that they should pursue geographic variability. It could just be determined by the dispensary and what they feel like would be the best service to them as an agency, perhaps.
Yes, from a regulatory standpoint, we prohibit proximity to certain other types of businesses, but we don't say where they have to go.
Okay. Mr. Chair.
Continue.
Would it be helpful to have some direction because even within the Southwest Health Planning region, which is pretty broad and vast geographically, there are just huge swaths of lack of access, whereas you can just run up and down I-81 and get whatever you need, but if you go east of I-81, there's really nothing.
And again, this is problematic of this limited licensure model where we've only said you can have 6 in an entire health service area. HSA 3 is huge.
Yep.
We're only allowing, at this point, 6 sites in there. So, I think that different states have dealt with expansion in different ways, but really this would be something that would be excellent for the regulator to assess where the needs are. I know that certain municipalities have reached out to the processors, begging them to locate in their areas, but they can't because that's not an area that they serve. And Charlottesville is a great example of that. They very much want a medical cannabis dispensary, but that license remains in lawsuit, and the next opportunity to address that will be June of next year. And even if it were resolved, which it's unlikely to be, then that's still 2 years before you would see a first site even built out.
Mr. I'll just stay in the
continue.
geography, and
Yeah.
then I'll let somebody else talk, and then I'll go then
Okay.
back. The next question I have is, do you have an idea of the timeline for expansion in Massachusetts in terms of, like, any idea how they got from when they started to? Do you know how long the program has been in place?
I don't, but I can refer you back to two reports that we produced in previous sessions where we did a review of programs in other states. We had a medical work group, and then there's some of this information you will see in the marijuana legalization work group report as well.
Okay.
Every state has their own approach.
Certainly. Mr. Chair, and the reason for the question is just that with some things and processes like this, tincture of time can resolve, some of the disparity issues around things like this, and you can't necessarily force the expedition of time. So I feel like it's an important benchmark for reasonable expectations, although I also appreciate the fact that we have limited patient access strictly by how we have designed the program. So I understand that.
Mr. Chair, I would add that this limited licensure model that we have is not common throughout the U.S. There are other states that have these types of models. They're typically conservative in southern states. Virginia has done an extraordinary job with the model that it has. We are the only state that has taken a very hyper-restrictive model with a singular condition and expanded it to this extent. So we've really done an extraordinary job with what we've been given, but it is not a sustainable model.
Okay. Thank you, Delegate Adams, and we'll come back to you if you have more later. JM, could you tell us a little bit about the status of the lawsuit, what court it's in, and when they are hearing or resolving?
They've resolved nothing so far, and I believe that as part of the appeal process, they're targeting it's either next June or July
To
bring it back up.
To the circuit court or the Court of Appeals, do you know?
I don't remember if it's in circuit or
Okay.
general.
Okay, I'm just
I
hoping
think
that we
it
get
is.
some resolution.
It's in
but,
Henrico,
yeah.
I can tell you that.
Okay. Then I'm curious about lack of product availability for certain products, how that's affecting patients.
So a number of patients rely on these products for symptom management, whether it's for a seizure disorder or for nerve pain, for sleep, for anxiety. And just as you expect your prescription medications or your over-the-counter medications to be there when you go to the pharmacy, they have the same expectations about medical cannabis products. However, as we touched on previously, it is this approval process that the products currently have to go through in Virginia right now, and the naming restrictions that we have that really limit the availability of products, because oftentimes the processors are waiting weeks and weeks for their products to be approved so that they can put them on their own shelves and distribute them throughout the state. And then, as I mentioned previously, patients may oftentimes be confused because the name is slightly different. Is this really what I'm looking for? Is this the same thing as what I had last month?
And that's a decision of the
Current regulator.
Okay. Of the regulator, whether or not they can use the same name, or they require the name to be varied if the formulation is varied? Or?
If there's a small variation in the formulation, it's a fairly low percentage that a product is allowed to vary based on cannabinoid content, and then it would require a new name. And we've tried to address this by keeping the word the same and adding a number to it, but that still causes issue for patients.
Okay, and Delegate Adams, you had a question on that vein?
Yes, Mr. Chair, first follow up in the same vein. Do other states have a benchmark for variances? Part one of the question. And the second is there interstate consistency about what that variance could be if they do?
No. Yes, other states restrict what other states regulate their product approval process as well, and what may be in that, but there's not interstate consistency in cannabis in general.
Mr. Chair.
Yes, Delegate Adams.
Is there any, has there Has there been any research or a documentation about what an appropriate variance would look like?
I mean, certainly we could ask the processors what they are experiencing in other states, and I think that would be an appropriate resource for addressing that.
Thank you, Mr. Chair.
Okay. JM, since Virginia has reduced barriers to accessing the medical program this past year, have we seen a major increase in patients using the program?
So we did eliminate the requirement that patients register with the Board of Pharmacy and get the physical card or patient ID number prior to shopping at the dispensary. Now patients simply see their healthcare provider, get their written certification, and that written certification is what allows them to shop at the medical dispensaries. This did increase patient participation in the program. To assess that, we would need to look at the processors individually to see how many patients they are serving, because patients are not required to register within any centralized system. So we could look at the prescription monitoring program to see what sort of numbers are in there. We could ask the processors how many patients they have registered at their individual sites.
Okay. And do we know relatively in other states that have more expansive programs, is the cost of the cannabis, medical cannabis, different? Is this limited sort of monopoly by health service area affecting the cost?
So I took a look at product prices in other states last night, as well as in Virginia, so that I wanted to see statewide what our pricing looked like. Our pricing in Virginia has come down significantly, and that's extraordinary. It's in some instances by more than 50%. Prices have been reduced, and I think that looking at edible products is a good example. When our edible products first came on the market, and these are gelatin cubes in Virginia or lozenges, when they first came on the market in Virginia, they would be you would get 10 at once, and they could be upwards of $70 for 10. Now we're in 30.
We're mostly at 35. I think the highest was closer to 55.
So its prices have come down significantly than when the program first started, and there were far more patients participating, and this is exactly what we expect to happen. More patients, costs come down. This is definitely, these prices that we're seeing in Virginia are definitely consistent with pricing on the East Coast in medical programs. I do not believe, based on what we hear from patients, that is their attitude. So we can look and we can see with our own eyes what prices actually are, but patient attitudes don't necessarily reflect this price change. And I think that's reasonable given that this isn't necessarily a product you just purchase once a month. You may need to purchase multiples for your pain management or whatever your symptoms may be. You may be purchasing multiple products. And these products, unlike other medicines, are not covered by insurance. And so that is certainly something that we could look at. No amount of supply replaces insurance coverage, and studying insurance reimbursement is certainly a move we could take here in Virginia. At the end of the day, this is medicine, and no one should be going broke buying it.
Thank you. Are there other members of the Delegate Herring?
Thank you. My question is, what is the methodology that would be used to assess demand to issue? And since we have, I'm just curious. Other than just saying this is the population. Because I don't think that's going to work just to say that this is a population, because the areas are not as dense in some regions. So I was just curious.
Do you mean by existing operators, how they would choose, or how we as a state may assess that?
Well, the issue that was brought up about sort of the location of the dispensaries and where it's sparse in certain areas in the Commonwealth. And your slide said that we could, one of the things that we could do is assess demand in a region.
Mr. Chair, I think that would be a great question for Jeremy Priest.
Sorry. Okay.
Well, we are going to, Mr. Priest is here, so let's ask
right,
him
I will hold
later in the
Thank you.
later in our
Sorry.
discussions. Sure. Okay. And then regarding Health Service Area 1, when the lawsuit is finally resolved, how long is it, based on when a license is awarded, would the timeline be to have a dispensary up and running?
It's been about 2 years in Virginia, but I would also caution that if this existing lawsuit is resolved, that doesn't mean there's not another one waiting to take its place. These licenses are highly contentious in Virginia. It's only grown now that we've expanded to adult use.
Yeah. And then as a follow-up in general, what would be the impact? People have come to me suggesting that it would be wise to have another operator in each health service area. What would be the impact in terms of competition, patient convenience, pricing, if that were to happen?
I think it's inevitable that this program be expanded. It was 2017 when it was a very different General Assembly landscape when we passed this bill and got to work on this, and the legislature then required this limited licensure model. As we've had more cannabis conversations in the General Assembly since, there's appears to be less of an appetite from the legislature to mandate or vertical requirement to keep licensing singular. In discussions we've had with adult use, it has been with a separated licensing structure where retail may be licensed separately than wholesale or cultivation. So I would encourage people to explore whether or not we would want to continue to mandate a vertical requirement in a medical program when we are specifically not suggesting that in potential adult use legislation. Doesn't really create economic opportunity. Granted that the work we do at Normal is specific to consumers. We are not a business organization. We are an organization that works specifically on consumer interests. And as we've discussed before, a lot of this conversation on cannabis in the Commonwealth has focused on who gets to make money first or next off of consumers, be they patients or otherwise. I think it's important that we, at least at some times, take a minute to put the consumers first in the interest of their safety, because at the end of the day, consumer safety is public safety.
Thank you. And on the advertising issue, you recommend for a basic advertising allowance. Is the code prohibiting that advertising?
Yes.
So that needs to be a change in statute?
Yes.
Okay. Thank you. Did you have another question, Delegate Adams?
I have many.
I think they've been informative, so let's keep going.
So getting back to the dispensary, would it be an appropriate solution to define in code what a medical dispensary, like the use of term medical dispensary for cannabis in particular? So
we do have definitions in code right now for what constitutes a cannabis dispensing facility. That's how we would refer to these locations, these retail locations. But we do not restrict use of the word dispensary in and of itself to licensees.
And would it be helpful to put more guardrails on that? It
would be. Consumers deserve that truth and transparency.
Just following up with Delegate Herring's question around methodology, one of the things that I see and I see that we don't have a way to capture is patients lost to follow-up. So, for example, there are many patients who may get a certification and ultimately never renew or continue in the program because it just wasn't the right medicine for them. and we don't have a real data set to capture that. So has there been any conversation about how we would look at actual, because even with medical certifications, that doesn't represent the number of people using medical cannabis. That would only represent people purchasing cannabis from a Virginia dispensary as a data point.
I'm not aware of any effort by the current regulator to assess that.
And Mr. Chair, the reason for that question is there's a lot of talk about lack of access to providers for certifications, and I'm not sure how we assess that exactly, and I'm not entirely sure if that is correct. That is a problem. Now, certainly, the issue around cost of products and everything else, that's a different discussion. But in terms of do we have access, availability, that is a question.
Mr. Chair, and this is common, this is consistent throughout the United States. When a state requires practitioners to register, a state will have decreased practitioner participation. We do require practitioner registration in Virginia at this point in time, and we additionally have health systems that prohibit their providers from certifying patients. Costs have come down for patient certifications, but we continue to hear from patients on a very regular basis that they feel that the certification itself is out of reach, is not affordable. And we also had the opportunity to do this. We were at one of the local news stations where we answered phones for a few hours. And we were all curious as to who exactly would be calling in at 4 o'clock to ask questions about medical cannabis. Mm. We heard from people who cannot read, people who do not have cell phones, people who do not have computers. People can't go to the library and get help with a telehealth certification. Mm-hmm. And it was really an extraordinary experience to hear from so many Virginians who had accessibility issues that we really do not consider in this program. It goes beyond, can you afford what's for what we now perceive as a more low-cost option for certification. There are a number of impediments to patients getting certified. It is not as simple as going to their existing healthcare provider and having that certification issued during the course of their regular physical. For some people that may be the case, but for most it is not. Most patients are going through a practitioner who specializes in medical cannabis certifications.
Can I ask, do we know what it costs typically to go see one of these certifiers, what they might charge someone out of pocket?
We see everything from $175, which is on the higher end, to $99 being about the lower end.
Okay, thank you. Delegate Adams, do you have more questions?
Yeah, this may be a statement or a question, but I think all of those variables that you're talking about are true, right? But what is also true is we need to think about this. Are we going to really legitimize this as medicine or not? Because what we're talking about in some of these proposals is legislating the practice of medicine. And when we talk about certifiers, when we reduce it, it's a very reductionist term, then we're basically saying we might as well get a stamp machine, which is, if there are many issues at play. One, Americans are used to being insured. So when they pay a copay, it feels very different. It doesn't mean that the cost of their medical assessment and care isn't at this other rate, because that is equivocal, essentially. The second thing is that, again, if we're going to make this a valid medicine, it's going to take, again, a tincture of time, right? We are not educating students, and anybody who's already graduated has not received cannabis education. We don't have pharmaceutical reps coming around and like they do for new medications and educating providers. So it's critical that if you're going to provide a medicine to a patient as a responsible provider, that you understand the onset of action, the duration, the delivery methods, the side effects, the potential interactions. This is important information, which is why we added a piece of education. You have to be able to attest to that, and we have many other, methodologies. So there's ink everywhere on me. There are many other examples of how we require attestation. Okay, so if you want to add that to license renewal or make it $1, but at the end of the day, that is an important piece, is that we have that attestation. You mentioned having certifiers on site. I cannot think of a more grossly, I think it's disgusting, frankly. And the reason I do is because we have both the anti-kickback law and the Stark law, and that the idea that we would allow somebody to certify on site, why not just have recreational? I mean, it really doesn't. It feeds the machine that is the dispensary, which, I understand, why they would want to do that. But it is not a normal practice of medicine. You can't do that in the medical offices. There's a lot of separation between different types of practices that you have. And then you're also talking about expanding the scope of particular providers, which is also a huge issue. So, I think what's important is that we really figure out what the etiology or the origin of the lack of access is, and sort of work towards solving the problem rather than what we think might be the problem. Because, I've been doing patient care for 36 years, and patients often don't understand why some things are the way they are. And they can complain about them, but it doesn't necessarily mean that the solution that they think is the most obvious is the best solution. So I think there needs to be a lot more thought about that in terms of really understanding the implications. And speaking of implications, I think that what happened last year with basically doing nothing around hemp has created a beast that is very, very disturbing. The pictures that you're providing for the CBD shops, it's gotten so bold that people are just selling regular cannabis from other states. In the Richmond area, there's at least 2 places where somebody's bringing, marijuana cannabis from another state and selling it, and just feel like they're emboldened to do whatever they want because nobody's going to enforce anything. What do you think should be, kind of how do we wrap our heads around this and relative to the medical practice? Because when you have Delta 8 products, and I'm just picking on that, Delta 8's not the problem, by the way, it's all the things, right? But when you have those products being sold where you can get 20, right, for $25, and then you can get 10 gummies in the regulated market for $35, that's a big difference. And so, what are your thoughts relative to that?
From a code standpoint in Virginia, we currently use Delta 9 tetrahydrocannabinol as the determinant as to what a compound is. Is a compound marijuana? It is determined based on the amount of Delta 9 THC. Is a product hemp? It's determined by a percentage-based amount of Delta 9 THC. This is not scientifically accurate. It's entirely disingenuous, and it's not how we regulate cannabis in the United States. So, in the work group conversations, as a co-chair of the regulatory subcommittee for that work group, we looked at what other states do, what the best practices we're able to glean from over 2 decades of regulatory experience with cannabis in the United States. And the proposal that we put forward was to have a single regulator, and to have a regulator that can provide an ecosystem for cannabinoids in Virginia. The amount of THC should not be the arbiter of regulation. it's even, to your point, it's even worse now because there are so many other isomers and analogs of THC, which are also, if not more, equally, if not more, intoxicating. So this idea that we're going, I think that is the sort of the downfall of our current code, is that it is hung on this percentage, and then that will determine what it is. And I think this body well knows that that's not the method that we use for regulating cannabis in the United States. It is milligrams per serving in most products. And whether or not something has a certain number of milligrams of THC shouldn't be what determines the need for comprehensive regulatory oversight to ensure consumer safety. People set things on fire and inhale them, and how much THC is in it at that point is probably one of the least of their concerns. So that is, first and foremost, a single regulator that specializes in cannabis is probably one of the most critical decisions we're facing in Virginia.
Thank you. Thank you. We're going to move on to our other presentations in a moment, but there was a question for, unless other members had questions. Jeremy, okay, please. This is Sarah McPike.
Thank you, Mr. Chair. There's people down here, too. No, those are all good questions. It's all in jest. So I wanted to follow up with the questions of, I guess, we might get to the regulatory status later on. Is that the plan, Mr. Chairman, in terms of the status of the current, what's on the books, and when they're going to be reviewed? Okay, and then follow-up, can you provide, you cited earlier a list of examples of zoning restrictions. Mm-hmm. Do you have a list of those, and are they specific to HSA 4? In general?
That we have some very minimal restrictions as to where
You cited earlier localities rejecting applicants. Do you have a list of those, or
it varies based on locality and what their claim is?
I would be interested in having the commission having that information, just so if there's other zoning updates or considerations.
Mr. Chair, I'm sure we could ask the processors to share what sort of rejection language they've encountered.
That would be really helpful for all of us.
Yeah, a follow-up question, Mr. Chairman.
Yes.
For HSA 4, the geographic distribution seems somewhat different than the other HSAs in terms of centralized cluster of distribution, and it appeared to me that like a drive is almost 2 hours in some cases for some that have an approved HSA distribution process. And is there a process in the reg? I don't think it's in the code, in the regs that govern equal distribution for equal access across Virginians?
No.
Mr. Chairman, I think that's also another gap for consideration, that as we consider any future legislation, that if we are providing a limited license, there needs to be provisions that guarantee some level of either regulatory review of equal distribution of those dispensaries, that guaranteed some level of access to that. And it seems like whether you're in Farmville or South Boston, driving 2 hours to have an initial consult may not be feasible of what product is appropriate. And so I just wanted to highlight that for the group. And one, I guess, final follow-up, Mr. Chairman.
Senator McPike.
I guess I'll put this into a question. Isn't it true that this is the loaded question, that, essentially because we have not really provided a strong framework for recreational use in Virginia, we now have a hodgepodge of so many loopholes that is actually encouraged the illicit market, and specifically based on the budget language that the governor sent down, that allows someone to have 100 pounds of cannabis within their household. You don't need to answer. Not to put you on the spot.
Mr. Chair, I think that's a valid point that you bring up. We did try a number of legislative remedies in the 2022 session, which, as you know, ultimately did not succeed. On the point I would like to make, though, as we continue to discuss this in the General Assembly, when we look at what an individual possesses legally in their home, it does stipulate that personal use and possession with intent to distribute in any amount remains illegal in Virginia code. So Could someone possess 100 pounds legally in their home? Perhaps, but if they were to exhibit any signs that this was, in fact, for distribution, that would be illegal.
Well, follow, Mr. Chairman, but
Sir McPike.
JM gifted me, David gifted me, Delegate Adams gifted me. I accumulated. That's how I got the 100 pounds in my house. I mean, there's all sorts of ways a defense attorney could like blow that out of the water in a second. And as long as you don't have a stack of cash, like you're pretty clear on this. I mean, at some point we've got to like I mean, unfortunately, the rest of our colleagues on the other side of the aisle aren't here present to actually dig into this issue and understand the impacts that we have unregulated products that are harmful, that have no consumer protection out there, and we need a recreational market that has those structures, and we can create a great Virginia brand. But this hodgepodge and ignoring the elephant in the room or not in the room is really killing us, and it's harming Virginians. Thank you, Mr. Chairman.
Thank you. Unless there are other members with questions, there was a question that you referred to, said Mr. Price from the Cannabis Control Authority would be better suited to answer. Which question was that? I'm trying to remember.
It was, I believe it was on process for assessing needs.
Okay. Jeremy, are you able to come forward? Sure. Okay. Do you want to switch spots with JM? Okay. Thank you for the presentation, JM. Very helpful and provocative, and hopefully will lead to some legislative initiatives.
For those of you who don't know me, I'm Jeremy Priest. I moonlight as the acting head of the CCA. My day job is as the Chief Policy, Regulatory, and External Affairs Officer at the CCA. So the question of methodology, there's certainly a lot of experience in other states. They've used surveys, focus groups. They've looked to see what products sold. They've also looked to see where patients were coming from, to see if there are deserts, so to speak, for location of dispensary and access. So we can avail ourselves of all these tools. There's also no shortage of economic consultants willing to undertake that analysis, some of them more compelling than others. We're also building right now our data team at the CCA, and this would be a focal point to collect data that would inform decision-making with respect to expanding the medical program, assessing demand. I would like to associate myself with JM's comments on the need for the expansion of the medical market, the overarching need. It is something, over the last 6 months, I've done quite a bit of traveling throughout the Commonwealth to meet with people on this. It's a consistent theme, this lack of access in parts of the state to dispensaries, and the uneven supply as well of cannabis products. Both those issues were consistently raised by communities that I've met with, and I think both of those issues need to be addressed. One other issue I would point out, unsolicited, is an endorsement of the idea of delinking dispensaries from the vertical integration model. The idea that we could have dispensaries operating independent of the pharmaceutical processors would open up economic opportunity in Virginia and also help us address the issue of access and geographical coverage. It remains to be said where these independent dispensaries, of course, would source their product. One option would be from existing pharmaceutical processors and any pharmaceutical processors admitted to the program in the future.
Okay, thank you.
Mr. Chair, can I ask a
Delegate
follow-up
Adams,
question?
sure.
Do you think that the agency would be willing to reevaluate how products are actually being approved. One of my biggest concerns is that I feel like the owners of the processors are driving based on profit. Medically, we decided that CBD didn't need to be necessarily a part of it, and that argument came from trying to use nasal sprays and some other delivery methods. But what's happening is when cannabis was made illegal in 1970, it was about 3-ish% THC.
Right.
The products that we have in the medical dispensaries that are most available don't look anything like cannabis. We have most patients that have medical needs often, most of them, not all of them, most of them need products that have CBD and THC in them because CBD has its own medical properties and mitigates the side effects of THC. They are the least available consistently. What is consistently available are products that, in my opinion, are not necessarily medical at all. Concentrates, butter, shatter, rosin, for most people. And what these high concentrations of THC, and when we talk about high concentrated THC, these concentrates are generally 50 to 90% THC. That does build up one's tolerance, and therefore you have to go back and get more. It's also hard to assess your own endocannabinoid system, which its entire job is to create homeostasis in the body, when you're bombarding it with what I would call a sledgehammer when it needs gentle strokes. So would it be something that the agency could look at is who's driving the decision of what gets submitted as appropriate products and what that balance would look like?
Yeah, we would certainly be open to doing that when we assume regulatory oversight of the medical cannabis program in July. I think the product approval process is ripe for reassessment. One thing on the issues you raise is that I do think we've probably distorted the medical cannabis program, which was originally conceived to exist side by side with adult recreational use or adult use retail market. And as a result, medical cannabis remains the only legal game in town. And I think that is why you have seen some of these uneven supply issues, but also why you've seen specific types of products that you might not normally associate with medical cannabis being sold in medical dispensaries. That's another example of Senator McPike's observation about kind of the hodgepodge nature of things, is that I think our medical cannabis program would look a little differently right now if adult use coexisted side by side.
Thank you. Thank you for being here, and don't go anywhere because we're going to probably have more questions for you later in the
Sounds
hearing,
good.
if that's
Thank
okay. Okay. Now, I understand that Brandon Thorpe from Sativa Testing Laboratory is with us today to present. If you want to come forward. Thank you for being here.
Thank you, Mr. Chair. Good morning, everyone. My name is Brandon Thorpe. I'm currently the lab director at Sativa Testing Laboratories in Chesterfield, Virginia. A quick introduction to me and the organization. So I've been in Virginia my whole life. Was raised in Fairfax County, went down to Blacksburg, Virginia, to Virginia Tech for bachelor's in biochemistry and a PhD in organic chemistry. I helped some professors between there and UVA launch a startup based on preclinical development of some kidney disease therapies, which unfortunately hit the biotech valley of death and we ran out of money. So then I spent a little bit of time in a nonprofit doing some interesting work with the Department of Defense on actual behavioral research on trying to turn the bullets and bombs tactics into winning hearts and minds battles in the Middle East, which was an interesting project. But then in 2019, after the signing of the Farm Bill, I was called to to come help stand up what is now Sativa Testing Labs. Back then, we didn't have a name. So I've been involved in the industry as old as it is in Virginia, and I've seen the evolution of the industry and the challenges that we've tended to face. And so my goal here is to try to help bridge some of the gap amongst the stakeholders in this industry. And so for the 2020 and 2021 years, we did VDAC's hemp compliance testing for the state. And now that's under a different USDA guidelines where folks can actually choose their own sampling agents and their own labs. But we saw a lot of the hemp cultivation and CBD product manufacturing issues there. Most recently, about 2 months ago, we had Secretary Matt Lohr and Deputy Secretary Parker Slabaugh through the lab, along with Aaron Williams, the program manager for hemp, to talk about specifically on the hemp and CBD side, their concerns and bridge some of those gaps as well. Delta 8 is their big enemy right now, obviously. And then last week we had Delegates Wampler and Robinson, along with Henry Watkins from Senator Evans' lab, sorry, I'm a lab guy. Office. And Andy Block from UVA as well, through to talk about sort of the larger adult use issues and also some of the existing issues we continue to face in the CBD market. And so I wanted to start off with an actual overview of the cannabis testing process and how complex it actually is. It's way more than just buying one instrument, sitting it in your basement, and running samples through it. We are testing for all sorts of different entities, and some of them are for the purpose of ingredients labeling, like cannabinoids and terpenes are for ingredients labeling, and then there's a whole slew of them for consumer safety, including pesticides, mycotoxins, solvents that may be used in processing, heavy metals, microbial contaminants. Foreign material is one that we're not currently required to do in Virginia, but other states are, and that would be looking for animal hair or feces or a chunk of rubber from a conveyor belt in a processing facility, things like that, moisture content, water activity. And in order to put all of that together, you really need to have expertise in organic chemistry, inorganic chemistry, microbiology, material science. There is a quality and regulatory piece that is needed to pull all of this together, and someone has to run a business and actually make it money, right? Because we are for-profit entities. So that you don't really find that package in a single person. So it does take a team of expertise. On top of that, you typically need dedicated instruments for each one of these analyses. So if you visit a cannabis lab, you're likely to see the pesticide instrument, the cannabinoids instrument, the metals instrument. And along with those, you have dedicated trained staff who are specialize in at least one, sometimes a couple of these instruments. They have to qualify on these specific methods and continue to demonstrate their capabilities. And each of these instruments oftentimes have six-figure price tags as well. And in terms of facility, there are special requirements there. A lot of these instruments draw very high power, and require their own ventilation. Then we have to have the larger safety hoods for ventilation of hazardous fumes. We have a clean hood that actually keeps the products clean when we're doing microbial analysis to make sure that we're not contaminating the products. Security is obviously an issue when you're talking about cannabis products, so we have certain physical security measures in place. And we also have to be able to deal with hazardous materials and gases, both in storage, use, and disposal. So my point with all of this is it's very complex operations. It takes a lot of money and a lot of expertise in order to stand these things up. So they're not something that you can just launch really quickly. And if the need in Virginia for more labs increases quickly, they're not something that can just stand up in a month. They take months and months, if not up to a year. And that's an issue we have seen in other states where they get behind, and then all of a sudden a typical 1 week turnaround time turns into 3 weeks or 4 weeks, and then it becomes a huge bottleneck. ISO 17025 accreditation is one thing that I want to point out that is very critical, that is very time consuming. That is your quality management system. Basically what that encompasses is all of your paperwork, your documentation trail, anything that comes through the door in terms of your solvents, your staff training, any of your testing materials, anything like that. Everything is tracked. What's used, who used it, when, if you made solutions, what did you make them from, where were those components purchased from, and the whole idea behind that is that it provides legal defensibility, and in terms of a consumer safety consideration, that is certainly important, because you can be sure that if someone were to get sick, they would take it to court, and that's what the lab's job is, to bring that packet of information and say, look, we tested this for pesticides, they were not in there, here's all the documentation, here's who did it, so on and so forth. Proficiency testing is wrapped into that accreditation as well, which is basically twice a year you get blind samples for each type of testing. So you'll get a pesticide PT and a mycotoxins PT, cannabinoids, and that's just to make sure that you are, you're actually generating reliable results. One note on those is sometimes they have, I have a little bit of a love-hate with the PTs, because sometimes the acceptance criteria is so wide that it's impossible to fail. They will say your results are going to be between this certain range, and your acceptance criteria will actually allow you to be wider than that range. So if you were to just blindly pick the number in the middle, then you would pass without even actually running them. So there are some considerations with proficiency testing and
submitting the blind tests.
There are some organizations that are that you can purchase them from. So
but you know that when you get them to test, you know what you're looking for already.
Sometimes they give you ranges on there, or they'll say these are the analytes for metals, for example, it'll say there will be one or more of these 4 metals in this range of 5 to 50 parts per million or something like that. So, generally what we do, it's hard to keep it very blind. Cannabis labs are typically small teams, right? We use a lot of robots, but the teams themselves are smaller. So it's hard to keep it blind, but the ideal is that you try to submit it as a real sample and your analysts don't actually know about it. That's the ideal, but it's not always ideal. So I have a list of the type of products, and the point is that there are a lot of different routes of administration, right? Smokable flowers, concentrates, vapes, different kinds of edibles and drinks, topical suppositories, nasal sprays. The jurisdiction in terms of the hemp and CBD market has been one of those points of confusion for over 3 years. There hasn't been a whole lot of clarity that has been added to that. And so, for example, the hemp cultivation, only up to the point of harvest, is overseen by VDACs. Then their food safety program looks at any sort of extracts that are turned into products intended for oral consumption, oral human consumption. But that leaves an entire, for years we've had an entire product lines that have no jurisdiction over them in terms of product safety testing. CBD, topicals, inhalables, any other things like that. And so, our clients still, folks that we've been working with for 3 years, are still confused about the regulations they're supposed to be following, those who are trying to do it right. Of course, all medical cannabis products go through the Board of Pharmacy. And then we have the CCA to consider with the adult use, and the challenge from the lab side is that we need to be able to serve all verticals. So if each one is completely different from a regulatory perspective, we essentially have to have 3 sets of methods in the lab. That makes things more difficult for us to stay proficient. It makes it more expensive for us, and which in turn makes it more expensive for the producers.
Delegate Adams has a clarifying question.
So are you saying that
Mike.
Are you saying that there are different standards for testing, whether it's like a hemp-based product or a medical cannabis product, for example? Is that what you're saying? I'm just trying to be clear.
Right, like a different, like a different list of solvents that you would ask for example. So if it's a CBD product, there's a certain list of solvents. And a medical product, if you had a different list of solvents, you would, on the instrument side, on our side, you would have a whole different method to look at that different list. And so each different list of things that we have to maintain make it more challenging, and also that gets into the interstate commerce question as well, as if we're trying to do a test that's compliant with Maryland or then compliant with Florida also.
But does that mean, I'm sorry, I'm just trying to understand. Thank you, Mr. Chair. So are you saying there's a different list, like in our regulations, there's a different list of what you should be testing for if it's a consumable hemp product versus a consumable like medical cannabis product? Is that what you're saying?
We're pulling them together a little bit better right now and adding clarity, but it's more of a large difference between states, from state to state.
But in Virginia, I think Delegate Adams is asking, is that a challenge that it sounds like it was a yes, that there's a different list of what you're testing for based on what the product is, if it's medical or non-medical or CBD in Virginia?
Right now, it's pretty consistent across them in Virginia.
Okay.
So yeah, we're in an okay spot in Virginia.
So, Mr. Chair, so you're saying that medical products and hemp-based products that are consumable are tested for the same things, and then does that mean the cost is the same? Everything's kind of the same. It's just one process.
Yeah, right now, yes.
Okay, and just one more.
Adams.
Are you also testing for food grade quality? Because when you have a medical product, you have to have a certain grade of consumability based on testing results. You're saying that that's pretty identical for CBD products, basically, or hemp-based products?
I'm sorry, I didn't understand the question. We're not certified to food lab standards at the actual testing laboratory.
So nobody does the food lab standards on the hemp products?
Not on the laboratory side. On the manufacturing side, they do. So there are folks who are inspected by VDAX Food Safety who are the hemp processors manufacturing the CBD products. They are inspected to food grade standards.
By other labs? Is that what you're saying?
By VDAX inspectors.
By VDAX themselves. Okay.
Correct.
Thank you. When you continue then.
So some of the current trends that we see, kind of what we were just talking about, state to state and department to department differences in testing. It's just a concern of when the adult use market, when the regulations for that come out, what are those testing requirements going to look like? Are they going to just copy and paste from Board of Pharmacy or VDAX or not? Part of the challenge there is those were copy and pasted from other states, and so we're copying some of those issues. Right? There are certainly pesticides on the list that don't need to be tested for, solvents on the list that don't need to be tested for. These do increase the costs there. So, if we just simply copy and paste, we're copying those problems. But if we make a different list, then we're creating the problem I was just talking about having to maintain multiple analysis workflows. So it's definitely something that we should consider carefully, I believe, with an eye towards federal legalization. The state-to-state differences are going to be a huge burden for us to sort out, essentially as a nation. One big problem that we see right now is lab-to-lab variability, which has ultimately led to lab shopping. This is more of a national level thing. I'm not really targeting Virginia on this one. And this is something that's been a constant work in progress in the laboratory space. And when I first started in 2019, there was a huge lack of any sort of standardized methods. We had very, very little to go off of, and so we essentially just made up what we, to the best of our abilities in our lab, we made our methods up, and then we validated them. There are a lot of groups that are putting out standardized methods now, like ASTM, AOAC, and USP I've listed here. One of the challenges with those is that they're very focused in. There will be cannabinoids testing in flower using an LCMS instrument, very, very specific. One of the challenges that we have on the lab side is that that's not the only type of product we get, right? In a shipment, you can have some flower and then some gummies and then the topical. And if you throw gummies and topical into that method, you're not going to get accurate results. So trying to fit a one-size-fits-all and a standardized method is difficult, but there's definitely a lot of work going there. And so at some point, it may be worth in the regulations to start either recommending some of these methods or pick from this list, or at least have some sort of performance requirements that if you develop your own method, it has to at least hit these performance requirements. And that should definitely help. One thing that we've seen is there's minimal oversight or double checking of lab results, and there's a rise in a number of lawsuits across the nation right now, including labs related to some of these issues and fraudulent lab reporting. And so one thing that a lot of states are looking at is, and some are actually already in motion, is building a state reference lab that would be double checking some results from the actual private labs. Might be something that could be used to select random products from the shelves and test those as well to make sure that the results are consistent. So that might be something to consider in future budgets. And what I wanted to run through really quickly are some examples from past test results that we've seen, and just highlight why it's even important that we look at these things. So, in a lot of cases, you do see large potency discrepancies between a package label and what is actually tested. The problem with that is that someone might be taking a larger dose of THC than they intend to and have a bad experience as well. Microbials, I would say, are probably the most difficult one because they're difficult to control. These are botanical products. They are a natural part of growing a botanical product. They're also easy to contaminate after the fact. So even if you're completely clean, you put them into a package that is not clean, then you have contaminated with them. Mycotoxins are related to the microbial growth, and so we don't see them that often, but that's we did definitely see that early in the hemp space when people were not thoroughly drying their products, and they would get moldy, and you would see mycotoxins as well. And so now post-harvest remediation is common in Virginia, but it's still one of those topics where state by state is very different. There's a huge disagreement on what the definition of safe levels are, particularly for testing total aerobic microbials, just total bacteria. It's not necessarily bad for you. And so recently in New York, they're rolling out their adult use market right now, and they had some pretty strict requirements for total aerobic plate counts and total yeast and molds. They got a lot of pushback that all of their products are going to fail. So they said, okay, fine, we'll just take away the pass-fail, but you still have to test for them and report them, and it'll be up to the consumer to decide, which I think is a terrible strategy, because who's going to know if 15,000 CFUs per gram of total yeast and molds is bad? I don't know, right? Then, yeah, right. I don't know either, I do this all the time. I just do the testing. So the microbials are going to be definitely difficult, and outdoor grown products in Virginia definitely have problems with high levels of background microbials, but again, it's not necessarily bad. So putting arbitrarily low numbers on that as an action limit, it could be very difficult for folks to actually be able to create products. Solvents, the idea from that is that you're just trying to test for whatever the person used. So you just need to make sure that things were fully removed from there. There was a case where for one of the medical dispensaries, they were allowed, at one point, they started to be allowed to buy CBD from Virginia producers, but they were not allowed to use petroleum-based solvents for extraction. And then there was a pretty low amount, but still a little bit of hydrocarbon solvent that was identified in there. Without that testing, that would not have been identified and then rectified. Pesticides and fungicides, we have had some issues with some of the things on there are OMRI certified organic, and you have organic farms. They use what they've always used, and then they end up failing based on the regulations. So there's there's definitely a discrepancy in what is an allowable pesticide in terms of organic farming versus what's allowed for normal fruit and vegetable production versus cannabis. So there's work to be done there, and another reason that it's important to test for these is we've seen contamination not from someone who is actually creating their or cultivating their own cannabis, but they sent their product off. It was an organic farm, sent it off to a processor to extract the CBD from it. They got it back and tested it, and they found 3 different fungicides in there. And of course, these are angry phone calls that we get, and this can't be right. Where did it come from? But it turned out that someone just was not cleaning their equipment well enough. And so, without checking along the way, that you just won't know. And so having untested products is just a bad idea because, even with the best of intentions, these kinds of things happen. Metals, we're not really seeing much on the heavy metal side, but there's definitely growing concern over leaching in vape products, so that's something to consider. The challenge with that one is generally when we're testing vape products, we're testing the liquid prior to vaporization, but the exposure is post vaporization. So there's a sort of a growing interest in testing the vapor itself, and again that adds to the complexity of the lab. We've seen minimal stability testing in Virginia. I think at least with the medical producers, I don't think things necessarily stay on the shelves long enough to warrant a 12 or 18 month shelf life study right now, but that will be as the supply increases, particularly with adult use. That would be something to consider is, at what point would you need to do stability testing versus setting an expiration date, because we know that cannabinoids degrade over time, and certainly microbials can grow over time. So, and we have seen degradation of cannabinoids. We have folks that say, I have my CBD oil I extracted last year, I never sold it, can you test it again? And you do see minor changes in the cannabinoids as well. So, some sort of just standard, you need to test a product at least every 12 months or something along those lines, I think would be helpful guidance. Currently, right now, we don't have batch requirements other than the medical producers do have batch numbers, but there are no real requirements on a batch cannot be greater than X amount of pounds or things like that. And on the hemp and CBD side, we definitely don't have batch requirements. And so, on the lab, you get sample 1, sample 2, sample 3, and we've certainly seen the reuse of our certificates of analysis for multiple batches and multiple years. And even on unrelated product lines, it'd be a flower test result on a website saying this is valid for all the things, the gummies, the lotions, it's just one result. We're good. Right? They get their compliant result. And so actually having batch requirements is definitely important.
Who would institute that? Would be the Board of Pharmacy in this case, or the Cannabis Control Authority when they take over?
Cannabis Control Authority.
Okay.
Yeah.
Delegate Adams.
So you're saying that the medical program isn't doing this, or the hemp isn't?
The hemp is not. The
And
medical do have batch numbers.
I thought they did.
But there's no limit. And so in other states there will be a limit on number of pounds that can be in a batch. To my understanding, we don't have a batch size limit.
Does Virginia
currently
require cannabis-specific accreditation for this kind of laboratory processing?
Not accreditation, Board of Pharmacy registration.
It's just but nothing to ensure that there is standardized methodologies to everything across labs.
Correct.
And
Right.
is there an auditor? Here, sorry.
Not in Virginia, not really. So with Board of Pharmacy, we do have to have ISO accreditation in order to work with the medical producers. And the controlled substance registrations are not about the methods that we're doing. Those are about the physical building security, generally.
Fair. And,
Adams.
and do you have any kind of DEA licensure as well?
We do have that as well, and that's also just physical building security. And also sample destruction. They're concerned with diversion, so they want to know how you're getting rid of your extra, but it has nothing to do with the validity of the test results you're putting out.
So, Mr.
Delegate
Chair,
Adams.
would it be inappropriate to say even within our lab structure, it's the wild, wild west of labs?
I would agree with that.
Yeah, it sounds like we have a lot of work to do. Thank you.
Yeah. And it has gotten better over the last 3 years, for sure. And I would say that that's a national problem as well. And so, one thing that has come up also related to some of this is there's no third-party sampling of products. And so, at the lab, we only know what comes through the door. We have no control over where it came from or any manipulation outside of that. And so I would recommend third-party sampling. That is what is done for hemp cultivation right now, but that's it. And so probably one of the biggest issues that we've seen so far in the hemp and CBD space is it's essentially been voluntary compliance. Even though VDAC's food safety has guidelines out for the processing facilities, there hasn't been a ton of push on enforcement. I know they have additional funding this year, and they're ramping up their enforcement. My understanding is it's a little bit more focused on taking down Delta 8 than improving and building the hemp and CBD industry. But so there's essentially voluntary compliance with this full panel, full safety testing that is prescribed by VDACs for extracts intended for human consumption. And a lot of times what we see actually is just potency-only testing. And then that way we can get the label right of 10 milligrams per gummy or whatever, but it ignores all of the rest of the safety testing. And certainly most people have best of intentions in this industry, especially the ones that are still here after several years. But like I mentioned earlier, things happen accidentally, and we've seen I've seen metals in an ingredient that a flavoring ingredient that someone got into their gummies. I've seen metals leached out of the little 30 milliliter bottles that people put CBD oil in, and these are things you just won't know unless you actually test the final products. And in a lot of cases, these are not at toxic levels, but the lesson from the CBD market is testing must be mandated for every batch of every product.
Go ahead, continue.
Sure. So I have a link here at the bottom, the National Cannabis Laboratory Council, which we are a part of. My recommendation would be to look at this as a reference for a starting point. They do a good job going a little bit more in depth for each specific type of analysis and what has been done on a national level. They look at some of the standardized methods. They look at the pesticides that have been seen in other states, and then additionally pesticides that have been seen in 3 or more states. So rather than just copying a list, this is actually what we're seeing at a national level. And so it's a little bit more valid of a starting point, I think, for creating new policy. What we're doing right now is we're actually currently building a larger data set of those. And it started out as a small group, and I was not a part of that at the very beginning. They're wrapping more and more states and more labs in and collecting as much anonymized data as we can to see what we actually are detecting nationally and by what product type, by what region. And so we're trying to pull together data sets that can help inform policymakers. So this is a good starting point, I think. It doesn't really talk about the specific action limits of what should be passing and failing, but just what you should test in what product type and at what point of the process.
Yes, Delegate Adams.
Do you think other than just having like an overarching structure, looking at other states in terms of a methodology and structure, do you think it is as helpful to see what other states are testing for as it is to just identify, because most of the hemp is grown outside, like identifying like soil and just Virginia specific issues? Do you think that would be more helpful than sort of benchmarking national standards in this area, or what are your thoughts on that?
I think there are regional aspects to it. Particularly in Virginia, if you have a very humid climate, we tend to get wet Septembers, and then there's the need to apply fungicides that wouldn't be an issue. So that's part of what we're trying to essentially map in with that large data set is, are there regional issues? So I do think that considering the region is certainly important.
Did you want to wrap up the presentation? Is there more data that you have for us, or?
That's basically what I had. And I did want to say that with what Board of Pharmacy does is just full panel testing for every product at the very end. I've certainly had a lot of conversations with folks who think that that's a little bit overbearing, because there are times when you don't need to test for everything. So say you've created your CBD concentrate, your intermediate, you full panel tested that and you've proven there's no pesticides, no metals, nothing like that, and then you're going to turn that into a gummy and you're adding a bunch of food grade ingredients that have already been tested for metals, pesticides, things of that nature. Maybe you don't need to retest for those things that really won't change. You certainly need to test for the ingredients piece. How much CBD did I get into my gummy? Microbials, like I said, are easy to contaminate along the way. And if there was any sort of solvent processing, maybe you should certainly test for that as well. But retesting for things, it just increases the cost of production. It increases the price at the end of the day for the consumer. And so there's that kind of muddies the water a little bit on the process. But I think it's something that should be considered. If at the end of the day the final product is proven to not have metals, for example, whether it's directly by being tested or it's because all of the ingredients that went into that product have already been tested. So as a combination, there's confidence there. So,
thank you. In your experience, what trends concern you in the sort of contaminants you find in your testing? What kind of public health risk are we allowing to fester by not mandating more product testing?
For me, the biggest one I see is the microbials.
Mm-hmm. And for those of us who aren't scientists in the audience, microbials, if you could just define that again.
Sure. So it's basically any sort of background bacteria, yeast and molds, things of that nature.
Okay.
And the challenge with that is a lot of them are not bad for you, but there are certain pathogenic species to be concerned with, and they are also you should be concerned based on route of administration. Right? If something is inhalable versus topical versus a suppository, there are different considerations for which you might want to look at. So it's one of those things that everyone disagrees on also in terms of what matters and what should be tested when. So it seems like a big risk, potentially more from a lack of understanding as an industry than anything.
Mr. Chair.
Delegate Adams.
Just in follow-up, though, a lot of people that are consuming hemp-based products are not aware that there's a fair amount of research being gathered that these microbials in immunocompromised patients can cause significant harm. So, you kind of have to look at the long-term piece of it too.
Sure. Yeah.
Okay. Thank you for being here today, and thank you for an informative presentation. And I hope that we'll be able to move things along to have better and more appropriate testing for products. So it's very informative. Thank you.
All right. Thank you, Mr. Chair.
Now we have one more presentation on from our own David May from Division of Legislative Services on what the minimum necessary steps would be to establish adult use retail market. David, do you want to just kind of give us your thoughts on what we would need to accomplish this session to establish an adult use market?
Mr. Chair, and Henry told me that I wasn't going to have to do this. So thanks, Henry. Remaining steps basically for an adult use market would be, number one, finish fully establishing the CCA, which is mostly technical at this point. They're obviously established, but doing things like making sure they're under the responsibility of the Secretary of Public Safety, making sure they're getting the same retirement benefits and are considered state employees like all other agency employees, making sure that their law enforcement officers are in the definition of law enforcement officer throughout the code and have the same rights and privileges as other law enforcement officers. The second step would be establishing, obviously, a licensing and a market structure, whatever that looks like, whether we do it or the regulator, CCA, would do it, some sort of structure for obtaining a license and for these sales to occur, including, all of our testing, labeling requirements. We'd probably need some additional modifications to the criminal statutes to add some things once sales start, like underage sales. We don't have those right now because you just can't sell it, period, unless you're in the medical industry, and underage sales are allowed there under certain conditions. So yeah, I mean, that's pretty much it. There's a lot of ways to skin that cat, I think, but those are essentially the big items that.
Okay, and if I could ask Mr. Priest to come forward again, Jeremy, based on what, not just what Mr. May outlined, but what you've know in general, how many additional staff and what funding would you estimate you need this year if we were to move forward with a regulated adult use market, whether it was July 1st or July 1st of the following year? What additional resources would your agency need?
So I certainly want to be careful here. This is an estimate, and the devil would be in the details in terms of everything that's required. But using JLARC's November 2020 report as a starting point, I believe they said it would take $10 to $16 million a year for ongoing operations of the CCA in a adult use environment. So 10 to 16, if we took a middle figure there, 13 million. Right now we're budgeted at 8. So using that middle figure, that would be an additional $5 million. In terms of staff, JLARC has some reference points there as well. And I think they have almost 5 or 6 dozen additional folks that they speculate or that they estimate that we would need. I would say that the figure would probably be closer to a healthy fraction of that, say 35 to 40 additional individuals. And those would be split among administrative, compliance, enforcement. Those would be our big kind of HR commitments would be in those areas.
Okay.
And you know, again, in the world where the details matter, it would probably be a slightly larger figure if we were asked to, as a single regulator model, to regulate hemp, the intoxicating hemp products. Right now, that resides elsewhere. But I think we've heard a lot of information and presentations on the merits of a single regulator. So just throw that out
we
there.
heard a little bit about medical earlier, and I wanted to ask you, if you were assigned the responsibility of overseeing Virginia's medical program starting on July 1st, is that something you're comfortable that your agency can assume?
Yeah, we're investing in the staff and technology to make that happen, and we are meeting somewhat regularly with the Board of Pharmacy to ensure there's a smooth transition. And I think we would also be very focused on having a communications plan to ensure that patients, practitioners are assured of how things will operate. Basically, that there really will be, in the very near term, no substantive change in the program. It would be just a new regulator. But again, the potential for confusion is great, and so we're very focused also on having a communications plan that addresses that potential confusion.
Okay. Are there other questions for Mr. May or for Mr. Priest? Okay. Well, thank you for being here, and thanks for your continuing work. We hope we hope to have this session give you even more responsibilities.
Well, that'd be great. Thank you.
Thank you. And thank you, David. Okay. Unless there are other, is there any other discussion from members who are here? Okay. Well, then with that, we will adjourn.